Beautiful. It's fun to be talking to ourselves, Matt, isn't it?
It's good. Let's see if this works. Okay, great. 23 minutes. Let's go. Um, Great to meet many of you at dinner last night and to engage with a few of you out in the audience this morning. So I think we're really here to talk a little bit about AI, which I've been to a number of conferences in the last 4 years. It's about all I've talked about. So we're actually going to focus a little bit on what does this transformation look like? And so let me start by asking you, Spence, what do you think over the next 2 to 3 years, where do you think this expansion is going to go? And give us your thoughts on where the industry may be leading.
Amazing. I was planning to ask the first question, so it's great.
Always go first.
I have similarly over the last 3 years in different kinds of settings and seeing a lot of growth in terms of AI, not just from the side of development side of the AI. We have seen a lot of differences after the generative AI hype in ChatGPT that took over the storm in how we have seen this ecosystem activate. A direction that we are going, let's talk from a technical side and more on the clinical side. I'm a clinician from my background, so have to take the clinical route. So on the technical side, we have seen a lot of growth into generative AI. AI is not different. We have seen predictive AI tools, large language models being established for over 2 decades that radiologists have been using for over a decade. Where we are seeing is large language models and prompt engineering that is happening right now with ChatGPT, Claude, various kinds of consumer tools. We are moving more into the agentic era on the technical side, where a lot of these consolidation of large language models coming all together, where we don't have to have individual prompts to get a response. These individual prompts are turning into decision-making AI systems more connected. That also leads to, at the end, actions that will have human component to advise or accept or decline those actions. But agentic AI, how is going towards in the next 2 to 3 years before we move into the autonomous side, where autonomous AI does a lot of decision-making and prompt. So what's happening on the clinical side?
Well, that's how many people here are in healthcare? Okay, so healthcare is slow. And I think the appropriate, or maybe even should have been more laughter. I think we're very slow to adopt. I think some of that's actually probably legitimate. We are privileged to care for patients, and their data, which is really where the foundation of AI lives, is part of ours to protect. And so there are some security issues that are paramount for our success and to build the trust that we need in order to actually bring this in to the healthcare environment to be useful. So I think being slow is reasonable. We have seen probably one of the biggest functional and perhaps successful, I'll get into that in a minute, but is the ambient listening component of AI. It's really the first major healthcare event that we've seen. I don't know many that are in agentic AI, as you just alluded to. It's slowly coming, and very few are doing it on their own. Most are partnering in order to execute on that, either with Microsoft or someone else. And I think we have the opportunity to build a ton there that could be helpful, assuming that we do the other pieces right. And I think we're going to get into some of that as it relates to ethics, regulatory in a minute. So I think healthcare is slow. I think we've leaned in on ambient listening because it was a pain point for our physician providers. And I say physicians because the nursing component of ambient isn't quite baked yet. That cake is still sort of soft and squishy. We saw some success, but how you depending on how you measure success, not a lot of financial success there. A lot of feeling success. So, and I'm okay with that. We have a ton of issues with burnout in physicians. So anything that we can do to make them feel better is probably helpful to the overall goals. We did the research trial here with our group, and I thought it was pretty robust. It doesn't save a ton of time. So despite the fact that physicians feel like they're getting a tremendous amount of unburdening and they feel good about their jobs again, and their success factors internally feel good, and they report that, they're getting about 16 minutes back a day, which is enough to, grab a coffee, go to the bathroom, and maybe that's all it needed to unburden. We're not really sure that they're able to see more patients to generate more revenue, to offset the tremendous cost that we've borne in order to bring that to market. Nursing will be a different animal. There are a lot more nurses than there are doctors. That's a 24-hour business. That's an in-hospital burden that is tremendous. And there's a ton of regulatory components that go into that, as you know. So that's my view on healthcare today.
Absolutely. And I think, as you mentioned about a lot of times the ambient listening is one of the more core operational tool that we have seen scale, which is one of the other challenges across health systems. And how do we bring not just a new technology, but a new technology that can be implemented at scale? What Cleveland Clinic has done is for their approach of even choosing, they have identified similar, there was a cognitive burden, physician burnout as a pain point. They used a model of try before you choose. In 2024, they brought 5 different vendors, piloted 5 different ambient scribes for 4 to 5 months with 45 different clinicians across various criteria, the product quality criteria, physician usability criteria, the cultural integration into the Epic is the one that Cleveland Clinic uses, and the integration side. And while those were great, they choose the right product. Implementation of that takes so many steps as we think about going into all the way from, it's not just about deployment of the tool, but also post-monitoring of deployment of the tool to make sure that there's no performance degradation that happens as a part of ambient listening. And a lot of the things that are missed, yes, there's a great opportunity for the first time ever that patient voices are registered and documented as patient voices, not as an interpretation of a physician's perspective with ambient listening. And I think those are more from the operational side fascinating. From the clinical side, there are a few tools that we have seen now emerging and being implemented across systems. Like Mayo Clinic has now, on a scale, implemented this cardiac mortality model where we were just discussing earlier. It's a great model that identifies cardiac mortalities for patients with BMI less than 31. It works amazing. But with patients over BMI 35, the model is horrible. It does not work. And how they have now evolved their internal functioning is in their system, they flag whenever a patient is higher than the 31 BMI, and the physician has still the override capabilities that they will not use any of the decision-making that is synthesized as a part of the model. Below 35, great, work it. And I think that's how we're moving into a system where designing and incorporating into the workflows becomes that bigger challenge. Matt, I would be curious to hear from those implementation barriers, so many we can name. How are you seeing some of these being implemented, models in clinical side of the shop?
Well, the implementation of those models is few and far between. We are slow. But I think the development of the models is great. So we have a Center for AI Research that's based out of our campus in Winston-Salem, and they're looking at all sorts of opportunities. We're looking with various vendors to think about, and you mentioned voice a second ago, but to think about when we're talking to a patient with an ambient listening device, how do we take the voice and analyze it for diseases, changes in their cognitive functioning that is pretty interesting to listen through. And we were talking actually earlier, you and I were talking to Rich in the audience about sort of the things he's working on around behavioral health. There are clearly times where just listening and watching. So it's around the combination of clinical decision support, which I think physicians are reasonably good at. I think there's a video component to this where if you're watching someone, what can we glean from that? How can we use technology to help us understand what a child's movement pattern looks like in an exam room? Does that child have a developmental delay? Is that child someone we should be screening for ADD? Is there an autism component that we can ferret out sooner rather than waiting until the child is 2.5 or 3? There are those types of things that we're looking at. And I think that's where our technology won't be there in 2 or 3 years, because it'll take us 2 or 3 years to have our attorneys work through those details. Oh, doctor lawyer jokes are always good. But I think that's where the 5-year plan looks like. And if you compare that with what we believe technologically will be an exponential increase in the capabilities of AI, as you look at the chips and how fast they move and the power consumption and the cost, we're hoping that speed increases tremendously and that cost goes down tremendously. And I think that will really help us be able to innovate a little bit faster. So as we try to move our healthcare system to where the puck will be, we're going to devise basically a playground. I'll call it a digital playground because we don't know what to name it, where startups can come in and begin to use their tools in a sandbox and begin to use, the Advocate Health has like 10.8 million patients that are de-identified. We have a huge repository of data that if we can keep it protected and let us innovate faster, then I think we're going to get closer to being able to solve some of these harder questions. So I think the answer is I don't know. I think the next 2 or 3 years we're going to be stuck in a little bit of hemming and hawing. I know that one of our North Carolina legislatures has convened a roundtable for AI from the state level because currently we're not seeing a ton of direction from the federal level. I know you've worked in that regulatory space, and maybe we can transition the conversation a little bit to how does DIME help navigate this very strange regulatory environment that we've seen in the last few months, and what do you think is going to happen from a regulatory perspective in the next 6 to, I'll say 20 months. And then after 20 months, I have no idea what to think.
I was going to say it changes every week, so 20 months is a long timeline. But yeah, I think in the regulation space, a part of my work is also to work with government agencies, looking with FDA, CMS, OSTP within the White House, both on the last Biden administration to now looking into the newer administration. We had in the past administration, more priorities that were AI safety were prioritized. AI post-surveillance systems, federated networks were prioritized in the last executive order. We are waiting till June for this administration to come up with their newer AI policies and administration. A lot of things will evolve underneath. And currently, as you mentioned, while for devices, we have some early systems and programs like PCCP, which is predetermined change control plan. So any kind of devices or digital tool with an AI ML component for it, there are 1,000 right now regulated FDA authorized devices in FDA's database that have been cleared through FDA. They have a program that uses PCCP, which means that when the submission happens through FDA, when a sponsor, vendor, a startup who submits the application, they have to disclose early on what the model's risk could be because of the non-deterministic data for a lot of these models, what risks could be, how the patterns are evolving over time. And this PCCP program actually allows innovators to have the confidence to continue to innovate and drive, and at the same time, FDA to have more confidence to make sure that model does not drift much farther than the intended use or the audience. However, we will not see, this is my personal viewpoint from the conversations across the industry, both private and public sector, a lot of these responsibilities will not be just federal regulations, that this is the regulation, this is the policy, everyone follows. I think now it's more decentralized. A lot of the responsibilities will be held into innovators' hands, developers' hands, health systems who will build their governance committees and models. And right now, 70% of health systems use vendor models into their systems instead of building it in-house models. So what does the governance look like? What does the compliance look like? What does the right performance metrics looks like for fairness, bias, transparency? Ethical components will still be a shared responsibilities with innovators and implementers like health system. And Matt, I know would love to hear your take on from the health system sides as you are working with innovators. One stat that blew my mind is right now there are over 60% health systems who use some kind of an AI model into their clinical support, yet only 16% of the health systems have governance policies. They have governance committees involved with people, but policies that there's an accountability component that goes behind, only 16% of them have. So how are health systems seeing this and how they are adopting a lot of these tools?
It's a huge challenge. I'm fortunate that our healthcare system is quite large. And so I think this is one of the few times that scale really comes to bear. Most of the time, scale makes it very difficult for us to move things out into the environment. But in this case, we actually have additional resources that sometimes small hospital systems don't have. And so as it relates to the evaluation governance policies, we knew from the tea leaves that this was coming a couple of years ago, began to write the policies and gather the right people and find who those committee members would be to sit on a fair AI committee and develop the policies, govern and review, and go so far as to actually look into the black box when able. A lot of vendors, especially in the early portion, weren't interested in opening the black box to tell us how they did things. But now there's a little bit more realism to it. They know that we're actually looking for the patient safety components. They know that we're looking to make sure that there's no drift. And we want to make sure that we do that for the safety of our clinicians and the patients that they're treating. So I think it's evolving, as you said. I think we do have policy, we do have governance, we do have a plan. It's woven into an IT governance, so you can't accidentally have AI. We had a couple of those early on where suddenly something got turned on. And usually it was some sort of an event where there was a poster or a celebration and someone said, look, we've been using AI. And all of us went, oh no. And so we're getting better at that. So I think if you're a small healthcare system and you don't have those resources, they're going to be looking to all of us to band together, actually. And that's where this community, this ecosystem that you referred to, is really important, so that we're all on the same page at the beginning. It would be reasonable for a smaller healthcare system to actually ask for help, even though they may be competitors in this space. This is new. I think we actually could all benefit from that. And I don't think it's going to be a costly event. I think the cost on this is going to go down. But right now, the cost is very high. I was on a panel in Chicago, and one of the panel members with the competitor healthcare system and said, I have to have this AI. It's the table stakes entry or doctors won't come to practice here. And I thought, something's not wired right there. I don't think that's the case. But that takes us to sort of the question of, what do doctors need to do? What do healthcare providers of any kind need to do? And actually, that's really an upskill. And I think that's sort of one of the things that we wanted to sort of touch on and open the mind around, which is, how do we take a group of folks who spent generally at minimum 12 years after high school learning a skill, and then another 4 or 5 years to feel really good. And so you're in after 20 years of training, someone's going to come to you and say, actually, forget about that. If you just look at this little AI thing, it'll tell you what to do. And I think that's going to be a very big challenge. What are your thoughts on that?
There are a lot of feelings hurt in the clinician community right now. And we know that because all of us, I remember sitting in the classes doing the cardiovascular ASCVD risk calculators on paper, and doing it on paper before the calculations went automatic to now they're already into systems. No one has to do those calculations. So medicine has evolved significantly. And I think one of the bigger challenges and a priority as a whole is, how do we not only reskill but upskill clinicians all the way from MDs, DOs, nurses, physician assistants on how they can leverage. This is not about replacing a job, but more so there is a lot of administrative waste that happens across the board. There's a lot of cognitive burden that a lot of clinical colleagues are burned out with. How can we elevate a lot of these concepts? And that's where we had partnered with Google around looking into generative AI, starting with what the generative AI capabilities and just basics. I don't think we, as clinicians, we don't need an arena where all the clinicians who are supporting or doing patient care are tech experts. That's not the goal. The goal is not to be tech determinist. The goal is to be, how can these clinical experts work and do their job a little bit better with extra time, with lesser cognitive burden, with the right tools that allow them as assisting tools to essentially do this work. And there's no going back. If the toothpaste of AI is already out, there's no going back and doing the traditional ways of doing. So I think we are in a generation, and I know there's another panel who will do a deep dive into skills and learning about what are the new skills we need to teach a lot of the clinicians.
And one of the comments that resonates with me is that there will be clinicians, physicians that that use AI, and they will outperform those that don't. And so that's actually pretty daunting to think about. But also, from an optimist perspective, it now gives me the opportunity to teach people how to use it well and to make sure that the tools that we have are the best for our clinicians and the best to use. And so that's what drives me to sort of get up and function on a daily basis.
It's funny you mentioned that because we are all learning about AI, using AI tools a lot of times these days is a lot of the articles and stuff feed it into Notebook LM, turn it into a podcast, you go for a run and you can read these. And there would be newer capabilities and models of learning and behavioral patterns. What we were discussing earlier is that needs to change. One of the key concepts that it still sticks with me and something that we have been thinking a lot around is this concept of trust. Building trust not only in our clinician community, but also patient communities. Because right now, what patients have seen across the board is their medical care being denied by United Healthcare groups, prior authorization being denied medications and access, and across the ecosystem. And we work a lot with patient communities. They have this fear of they have not seen a lot of good success metrics and stories of AI being used for positive benefit. They have only seen on the negative benefit. And I always go back to this. I'm a history nerd, so has anyone heard about the elevators analogy? History of elevators. So in 1950s, very different
Don't raise your hand.
Very different tangent, but UNC Charlotte, actually, Gary Lee, a professor of architectural history here in Charlotte, who had first identified and discussed about elevators. What was happening in 1850s and late 1850s is these mechanical marvels were moving these large commercial products from floor 0 to floor 7 in no time. They moved it into for humans and individual uses. What was happening is people were ready to walk in heels 10 floors or with those hats and sticks 10 floors, but rather than going into the elevators. So these companies had to put an operator, just a guy who says hello to them on the elevator, just for people to make it trustworthy that it's going to be okay. These are not going to change things. And I think we are also living in this similar cycle where we had to bring along a lot of our patient community. We had to bring along a lot of our provider communities by reskilling, upskilling, and also sharing a lot of positive success while it's going.
Well, and I think our patients are ready for something to give us. I mean, we've seen the erosion of patient-physician relationship over the last 20 years. And I think that this is an opportunity as I think patients are pretty tech savvy. I mean, I know we talk a lot about folks that don't have cell phones, or a lot of people have some ageism that says, oh, you can't use that tech because they're the 80-year-olds. I have an 80-year-old mother who's got an awesome iPhone and rocks it. So I have a hard time rationalizing that. And I think the elevator analogy is great, but I think people are going to hear and feel and use AI in other industries. And then they're going to turn to the medical community and say, how come you're not using this? And so we may have an opportunity to say, we are using it. And here's why. Here's how it helps you. Here's how it helps us be safer, faster, without the hassle of prior auth. That's a big one we should chat. We're going to take that one down here in the next year. So don't worry about that. Yeah. So I think this has been really helpful for me. And I think we're at time. So I think we're now ready for the onslaught. There's the first question. Go ahead. And we'll repeat them so that everybody in the back can hear it. Oh, never mind.
Thank you so much for a wonderful discussion. I get the sense that the conversation is really focused around doing things for people, doing things for clinicians, doing things for patients. Are there any stories when clinicians or patients become really full partners in implementing those solutions beyond the lip service? Full partners in terms of designing governance, designing like how those things are used? And do they come up with other success metrics beyond like 16 minutes per day saved? What does success look like for them when we ask? Thank you.
Take that one, I guess. All right. So I think that's an outstanding question. And it gets into the how do we build a partnership with patients in the care delivery that we're privileged to give, right? That the ideal care, right? You go see the doctor, they care about you, you get a series of distilled intellectual responses to your issue. And then there's a partnership that says, hey, there are a couple options here. Here's my expert recommendation. I think you should do this. But you could do these as well. Here's what I'm worried about. How do we bring AI into that clinical decision-making component? And I think we're not there yet, but we're close. As we've learned a little bit with our ambient listening and by putting AI-enabled cameras and audio into hospital rooms, we're starting to begin to enlist the patient and the patient's families on how they feel about the technology. I think that's our first step. Shockingly, the ambient listening is easy. They don't care. They realize it's writing a note for them. They're smart enough. Most people understand that. What I found so shocking is if you are completely at your worst in the hospital, because nobody likes to go to the hospital, right? That's not where you wake up. It's not what you want for Christmas. But you're in the hospital bed in various states of not your best dress and or naked, and there's a camera watching you. I would have thought that a lot of people might have had some reservations there. But in the last 2 years of us looking at this, we've had one, which is shocking to me, because we were able to explain that the reason we have the camera and the audio device is so that you can get help immediately, that you can have a nurse come on the screen immediately and help you. And so that, to your elevator component, is technology with an elevator operator. They don't know that that nurse is either 16 feet down the hallway in an office or in another building across town. But they feel good that someone is there to listen to them and address their issues. And I think that's one of our first steps to answering the question. I think there's many, many more. And as we engage patient advocacy groups on how they feel about this technology and what their responses are, I think we're going to learn a lot more, and maybe in a year or two have a better answer to that question.
Good morning. So my name is Summer Stanley. I took some notes, and so this might be a lengthy question, so bear with me, okay? I'm that person. No, it's for both of you. Don't point the finger. My organization, I'm the founder of Inclusive Scan. We work with healthcare systems, small and large. One of the most notable is Cone Health, to improve patient inclusivity and accessibility, primarily for marginalized communities such as deaf and hard of hearing, visually diverse, Asian populations, on and on. You get the drift, right? And so I'm curious, one of the things that we partner on, we are developing an API to stream software eventually through EHR so that patients can receive information in the modality that is most accessible to them. Most people don't know this, but deaf and hard of hearing patients typically don't read above a 5th, 6th grade level. So when they receive any information about education, it's not accessible. We're all following me so far, right? Yeah. So my question to you is, given your leadership in promoting ethical and equitable integration into digital technologies in healthcare, how are you, I guess, including accessibility for those patients? You talked about trust and barriers. That's a huge barrier. So I'm just curious, what are you working in that direction? Are you looking at any AI accessibility technology in that arena at all? If you could answer that question, or if you want to just tell me, you'll email me later, which is what I normally get, that's fine as well. All right. All right.
I can start, and if there are insights, Matt. I think this is an excellent question, and I think right now I'll share. We're working with the City of New York in the Public Health Department. It's less about the accessibility. We are taking a full spectrum on the equitable side of how do we remove racism and clinical algorithms as a starting point, because we know that medicine, we have so many clinical algorithms, 48 that we use for different kinds, like cardiac functioning risks, like ASCVD score, kidney transplant risk scores, VIVEC scores for cesareans, for birth for females. A lot of these risks are adjusted scores based on race and ethnicity and sex of an individual. These are the ones, the first is identification of where those gaps exist, is where we have started in building how do we de-implement a lot of these clinical algorithms that will create essentially more diversification than actually consolidation. And when it comes to accessibilities, one of the things that we have learned is when models are being developed and tested, what we are recommending, so we work with patient groups, we have patient advocate Grace Carndavos in our team. We work with a lot of patient advocacy groups like the Light Collective, who have built the AI Bill of Rights that includes accessibility as one of the core pillars, is a lot of models that are being tested, they need to have representative data. It starts there. The data of testing of a model, whenever it's happening, it needs to have a representative data that's going larger than below. Use case approach is another version of where limitations of accessibilities for individual hearing impairments for individuals are different than a large scale population where model has been tested in a non-accessible population. So I think there are a few directions that progress is being made. I think we have, just like AI, we are still figuring out those bits and pieces, and a part of the governance committees across teams are looking at those diversification.
We have time for one more.
So I was going to say yes, and yes. So we actually have a division through that reports to our CEO that is the Consumer and Social Impact Group, and I have to pull up my notes because they keep changing the name of the thing, and I can't remember it. And I'll get to it eventually. It's the Advocate Health National Center for Clinical and Community Impact, which was really designed to address these disparities. And if you're not really up on equity, it's $1 trillion healthcare issue for the United States. So as much as a lot of this stuff has been sort of pushed aside recently, I think the value there, independent of your politics, is really related to the financial outcome at its core. I'm not saying that's all it is, because you bring excellent points up, but this actually is about patient care. All of our healthcare information is delivered at the 4th grade reading level. What's interesting, and the reason I wanted to respond, I knew where he was going to go. He's dead right. But we've been thinking about using AI to actually make it harder to read your discharge instructions, because sometimes if you have a PhD in biochemistry, you do not want to have Jack runs to the doctor. Jack takes his medicine. Like, that's really irritating to you. So we're trying to figure out how to understand from the record, what is your individual level of learning? Okay, that's one group of it. But what is your medical knowledge? So giving instructions to a physician is a lot different than giving instructions to a biophysicist, but both have pretty reasonably high educational levels. And those are different. And I think there's a way for us to use AI to tailor that education perfectly for the individual, which is really what I think your core question is about, is how do we deliver the right message to the right patient that's theirs?
Yeah.
One more question, you said. All right, fire away.
Sean.
I can go without them. Okay, I'm Sean Sylvia from UNC, where I run the Digital Health Economics Policy Lab, and I'm CEO of Collective Good as well. So in my research, I've talked to a bunch of clinicians in different countries about their willingness to use like clinical support AI tools, right? And I give them this hypothetical question where I say, okay, so say you have a model that's supposedly 99.9% accurate, right? And it's giving you, say, like a certain risk for a patient, or giving you a differential diagnosis, or like how likely are you to follow the recommendations? And they all pretty much say the same thing, which is like, so absolutely, I would be willing to follow the recommendations as long as it aligns with my own training and and read of the case, right? Which kind of defeats the purpose. And a lot of that is because when you dig into it, in the US especially, it seems to be that liability is driving a lot of that hesitancy to just kind of trust the AI output. So I'd be curious to hear what you guys have learned or are thinking about in terms of, when we're using both kind of AI and have a clinician using AI and say one is wrong and one is right, kind of where does the liability fall, and how do we think about policy to address that issue?
Another keynote.
Wow. That last part was painful, but a really good thing to think through, considering that Advocate Health operates with 2 of the most litigious counties in the nation under our footprint. It's a very challenging question, particularly if a physician were to see information that was AI generated, or let's just keep AI out of it, just generate it, and then not take the advice. Okay, who's responsible? I mean, ultimately, I think the physician is responsible. As a physician, I think that's part of what we're trained to understand. On the flip side, much of what I think, and I'd love to, at some point, we could actually talk for a long time. I should have known that at dinner last night. I would have talked more with you. But a lot of this messaging is often over the shoulder messaging. And by that, I mean, you get it in your face and you look over your shoulder. I hope nobody saw that. Like, did I make that mistake? Like that's the power of alerting. And it's from its simple, hey, the patient's actually deathly allergic to this medicine you just prescribed. Parentheses, pay attention, close parentheses. But on the differential diagnosis, there's some ratification of I was thinking that too, which is really nice. That's a positive reinforcer. And then there's sort of I see that. Not sure I would have thought of that. Let me look into that. That's sort of the murky middle. And then there's well, that just surfaced, but it's just giving me a laundry list of garbage, and there's no chance that happens because this patient didn't travel to Africa. So I think I'm okay to ignore that. But what I think ultimately where you're getting at is what will that do to change healthcare? And I hope that will now change healthcare from what were ridiculous 95 and 97 coding guidelines to actually paying physicians and getting physicians to document the things that are inside their head, because that's what we are trained to do well, which is take multiple concepts and knit them together appropriately for patient care. So spending time talking into the microphone, or talking more importantly to the patient about the why, and engaging the patient in their understanding, to have support for that is really great. I mean, if you come in with a cough and I say you probably don't have Chagas disease because you haven't actually been there, the patients are going to go, yeah, I kind of agree with you. The likelihood they do is also quite low. So I think the medical legal risk there is difficult. When you get down to sort of some neurodegenerative stuff, advanced cardiac things that are, could be this or that, you probably ought to phone a friend and or engage the patient in the conversation. And I think that will actually lead us to a less litigious environment. But that's my hope. Keep going. Thank you.